Good evening and welcome to tonight's Men's Health webinar. Tonight, we have the privilege of hearing from Dr. Garrick Greear, who will present on erectile dysfunction and Peyronie's disease, their signs, symptoms, and treatment options. You are encouraged to ask questions during the presentation. You can submit them anytime. To do so, move your mouse on your computer or tap the screen of your mobile device. A toolbar will pop up in Zoom. Find the one that says chat, click on that, type your question in, hit submit, and we will answer those questions at the conclusion of the presentation. This is being recorded. You will have the opportunity to see this recording tomorrow, be sent to you. But just so you're aware, your questions that you submit in that chat feature are anonymous. Without further delay, I want to introduce Dr. Greear.
All right, Mike, thank you for the introduction. So my name's Garrick Greear. I'm a urologist at the Urology Center of Colorado, or TUCC in Denver. And as Mike said, I'll be discussing erectile dysfunction and give an overview of Peyronie's disease today as well. And these two are often related and neglected men's health issues. And just wanted to say thank you to Mike Robinson and Boston Scientific for organizing this event, and especially to Chip Pollock for joining us to lend a patient's perspective near the end as well. And this is part of a series of webinars that we were putting together for the community to raise awareness of conditions affecting men's health and their treatment options. And if you attended the last webinar, there'll be a little bit of overlap, but also some new material. So thanks for joining, and we'll go ahead and get started here. And so you can see my interests, my background, and areas of expertise here on the right. I value this educator aspect of my job, and this is why I'm here tonight. And hopefully you all can take away something new. I specialize in sexual medicine and reproductive urology at the Urology Center of Colorado, as we discussed. So learning about erectile dysfunction, it's important to start with kind of the basics here and have an insight into how your body actually creates an erection. And so the erection process involves a few things, including arousal, which is when the nerves around the penis become activated. The muscles relax and blood flows into the penis. The additional blood causes stiffening, and the erection then compresses veins that allow blood to exit. And so that allows these two erectile chambers, or what are called the corpora cavernosa, to pressurize. And oops, I was going to draw on the slide, but that didn't work at all. I'll not do that. And so what is erectile dysfunction? Well, this is defined as the inability to achieve or maintain an erection firm enough to have sexual intercourse. It's quite common. We know that more than half of men over 40 have some degree of ED, and about 1 in 5 men over 20 will experience ED, actually. And so this affects almost 39 million men in the US and more at this point, as this data was a few years old. There are many conditions that are associated with erectile dysfunction, some of which are causative. And the top 3 physical causes here are vascular disease, diabetes, and medications. ED can also be the result of prostate cancer treatment or hormonal issues such as low testosterone. But ED has a broad negative impact on health-related quality of life, and it's important to recognize and treat. Now, heart disease is the most common associated condition associated with erectile dysfunction, and it's important to understand why, and it can actually save lives. So erections rely on basically blood flowing in, healthy blood vessels. The penile artery is, about 1/3 to 1/2 the size of the main artery supplying the heart. And we find that when conditions like vascular disease, the deposition of cholesterol plaque in the artery, narrowing the artery, smaller arteries are affected before heart disease symptoms develop. And so what we find is that heart disease develops sometimes not until 2 or 3 years later after the onset of erectile dysfunction. And multiple studies have shown that ED is an independent risk factor for future heart-related events. And the severity of ED is often correlated with the extent of their coronary artery disease, which kind of makes sense. And so, the principle here is that you develop some ED, and this is because there's cholesterol here, plaque narrowing the artery to the penis, but you don't have any heart symptoms until much later as ED worsens and you start to have chest pain with exercise, for example. And then ED worsens further and you have chest pain at rest. And so it's a critically important association to understand because, ED, especially in a younger man who has some of these conditions that can be associated with heart disease in particular, this is an opportunity potentially to identify heart disease early, treat it, manage it, and prevent something lethal. Now, one of the other critical conditions that relates to erectile dysfunction here is diabetes. And as you know, diabetes, it's an epidemic in our country. As of, almost 10 years ago, over 15 million men have diabetes. Patients with diabetes are often less responsive to oral treatments for ED. And men with diabetes, ED is often more severe. And ED can also sometimes be the presenting symptom of diabetes. And so screening for diabetes is just a simple blood test and is generally routinely offered at an annual physical. And it's a very important thing to keep on top of. So how does ED cause diabetes, or how does diabetes cause ED, excuse me? Well, chronically high glucose or sugar levels in the blood, they damage the very fine blood vessels that generate erections, and also the nerves that mediate the signals for the erection process. So up to 60 to 70% of people with diabetes have some neuropathy or nerve damage. And the ED pills, for example, like Cialis or Viagra, they rely on these stimulation signals to be carried by the nerves and healthy blood vessels as well. And so if these are damaged due to diabetes, pills are often not as effective. But having diabetes does not guarantee that you will develop ED. As we age, though, the longer you have diabetes, if it's poorly controlled, or if you develop heart or vascular disease, these are the things that multiply the effects of diabetes and increase your likelihood of developing ED. So it's important to keep these things under as good a control as possible. Switching gears here, this is a topic I get a lot of questions about, which is the relationship between ED and low testosterone, low T. It turns out that low testosterone itself is difficult to define, and that's just because we're all different. For practical purposes, we have to draw a line somewhere, and experts mostly draw the line around the 33rd percentile. And so that means that to have low T, you have a lower testosterone level than the other 2/3 of men, either for your age group or just in general. The other challenge is that testosterone is variable. And so we know that a repeat testosterone check will often reveal a normal testosterone level about 30 to 35% of the time. So confirmation is important, and sometimes a trend is helpful as well. However, low T is common in men with the same conditions that can result in ED. So these things are often seen together. The causative relationship is often a little bit unclear, but it becomes more common as we age. And so for every 10-year increase in age, the risk of low testosterone increases by about 17% or so. Now, how does testosterone relate to erectile function? And this is essentially two main ways. It influences libido or sexual desire. And this is what kickstarts all of the physical signals that cause your body to generate an erection. But it also regulates at kind of a high granular level the cellular machinery for generating erections. And so not to get too technical, these are things like nitric oxide signaling or phosphodiesterase activity. And so this is how testosterone relates to erectile function. Screening for low T is usually something that we'll discuss at an initial consult for ED. Testosterone therapy, if you're diagnosed, is not without risk. There's always a risk-benefit calculation that involves your personal tolerance and your priorities. And it's my job essentially to help you understand that calculation and navigate that decision. Now, erectile dysfunction also relates to prostate cancer treatment. And so after skin cancer, prostate cancer is the most common cancer among American men. Here, I'll briefly review the influence of or the association here. One of the most common treatments for prostate cancer is the surgical removal of the prostate, or what's called a radical prostatectomy. The technique has evolved and has been refined over time, but no matter how perfectly you perform the operation, there's generally a little bit of stretching and trauma to these delicate microscopic nerves that govern erections, that travel right here along the prostate and kind of right almost through the prostate in some areas, the lining of it. And so most men will experience ED after a prostatectomy. And while function returns generally with time, it often does not return to the baseline that men have prior to surgery. Now, radiation for prostate cancer treatment also affects erections, but the effect is a bit more gradual. So what we find is that function declines a bit more quickly than it otherwise would have with age in these men. So if you look at sexual function scores about 5 years out from either prostate cancer treatment modality, men who've had radiation or prostatectomy, they're about at the same place, which is just a little bit worse than where they had started. And so if you've been diagnosed with prostate cancer, it's important that your prostate cancer expert has a candid discussion about this side effect of treatment. In our practice, these experts are in constant collaboration with me, and I have a substantial portion of men who've been treated for prostate cancer. We're almost always successful in finding a treatment option that allows them to return to intimacy, whatever they wish. Now, let's go over treatment for ED first before we launch into Peyronie's disease. Now, what can you do if you have ED or if you're worried about developing ED? Well, the first step is optimizing lifestyle, which will also just decrease the risk of things like heart disease. I'll just briefly tout a recent study, a meta-analysis that looked at 11 randomized controlled trials, and they found that a protocol of just 30 minutes of cardiovascular exercise 3 days per week led to meaningful improvements in erectile function. And so, interestingly, more improvement was actually seen in the men who had worse function. So there's a little bit of a, there's more bang for your buck if you're worse off or you're not as fit. And in those men, the effect was almost as comparable to that of medication like Viagra or Cialis. So it's just kind of crazy to think that just exercising can almost be as effective as Viagra. Similarly, another very important health change you can make is smoking cessation. I talk about this all the time for those men that it pertains to. The impact on erections from cessation can almost be seen immediately. And they've done ultrasound studies that show that just 24 to 36 hours after you stop smoking, there are changes in blood flow and improvements in blood flow. And in men who are successful in quitting, they find that there's about a 25% improvement in erectile function a year out that's durable. And now the other condition that does not often come to people's mind at first is sleep apnea. And so severe sleep apnea can induce changes in the cardiovascular system that worsen erectile function. And adequate treatment with a CPAP machine, for example, in one study led to improvement in erectile function, again, on par with change seen with medication like Viagra or Cialis. This is a small study, but it's striking data, and it is a clear contributor to erectile dysfunction. Moving beyond lifestyle modification, though, these are the main treatment modalities that we'll talk about today, and I'll talk about some other investigational treatments as well. The treatment of ED was, and I've alluded to this already many times, but it was essentially revolutionized by the discovery of medications like Viagra. I advise most men to consider these as an excellent first step. These medications are generic, so they're very affordable. But the reality is these medications sometimes don't work well enough, or there are bothersome side effects. And I've had some patients, for example, where every time they take this, they have really severe nasal congestion, they can barely breathe. And that's uncommon, but for him, that's not a good solution. And they aren't a good long-term solution, as we know from just the data in about half of men who try them. The other form of therapy after pills no longer work, for example, is to consider would be penile injection therapy. This is an excellent solution for moderate to severe erectile dysfunction. The way this works is that men will learn to self-inject medication directly into the penis, and the erection develops usually within about 5 to 20 minutes after the medication is administered. I have an example here, and it may be difficult to see on Zoom, but it's a very tiny needle, very narrow needle, short, small syringe, easy to handle. And part of this is just there's obviously a barrier to this, kind of an emotional, psychological barrier for many men. But those who learn and feel comfortable with it tend to be happy for a while. We find that about 40% of men will discontinue the therapy usually within the first 6 months for one of these reasons. Either they have pain, they could have a prolonged erection. This is a risk of this injection therapy called priapism, which can be dangerous, scar tissue, or bruising complications, things like that. The most common reasons are just that it can be variable. The medication degrades with time, or if it's not stored properly. And so it's frustrating for a lot of guys to have it work one time, and they do the same thing the next time, and it doesn't work. And obviously that is that's a significant mood killer and a barrier to spontaneity. So another easy treatment that we'll talk about is a vacuum erection device. This is, essentially a mechanical solution. So this is a negative pressure pump that uses a vacuum to pull blood into the penis. And then an elastic tension band is placed at the base in order to maintain the erection. And satisfaction rates vary, sometimes between 60 to 80% or so. It drops a bit with time. The most common side effects are just, it kind of tends to block ejaculation. That feels unusual. It may cause some bruising from the constriction or from the negative pressure. It can be uncomfortable from the band. And some people will be bothered by the fact that the erection feels a little bit cold compared to what they're used to, because the blood is trapped there. It's not constantly circulating or being fed by arterial supply. And so in many men, it just does not work for them. Another option here, which is becoming increasingly uncommon, really, is a urethral suppository or gel. There's a commercially available one called Muse, which is a prostatil pellet. This works by basically, after you empty your bladder and you insert this little tablet or gel into the urethra, the erection, you hold it there, it absorbs. The erection develops within 5 to 10 minutes. It's effective in many men, but often causes discomfort. Some people may have a little bit of urethral bleeding. So those are the main reasons for discontinuation. Some alternative or investigational treatment options that I'll touch base on. The most widely advertised of these is the shockwave therapy, or low intensity ultrasound extracorporeal shockwave. This uses focused ultrasound waves in order to induce changes in erectile tissue. And data suggests that it may improve microcirculation or blood vessel health. It can recruit natural stem cells to the erectile tissue, potentially for repair, reduce fibrosis, or encourage nerve repair, for example, in some animal studies. Some of these benefits have been difficult to demonstrate in humans, and the data suggests that perhaps this is most effective in men with mild erectile dysfunction related to vascular disease. It can maybe restore responsiveness to oral medications. It does not seem to be as effective in men with diabetes, Peyronie's disease, or in men with ED related to pelvic surgery, for example. There are many questions still about how long the effect lasts and what the best protocol is. But ultimately, it's a safe, non-invasive treatment that is not pill and injection or something else like that. So a lot of men will opt to try it. It's not FDA approved or covered by most insurances, and so that's a barrier for a lot of patients. A lot of questions I get are about injection of other things like platelet-rich plasma, which is used often for orthopedic injuries, but it has been difficult to demonstrate any sort of efficacy for erectile function. There was a relatively recent small, well-done trial that just compared PRP injections to a sham injection treatment and really found that it was safe. There were very minimal side effects, but there was no benefit over the sham treatment, at least at 6 months. And the challenge is just, trying to understand what this substance is actually doing, and I don't think the data is there quite yet for this treatment. Similarly, stem cells, these studies are small and not very well powered, and it hasn't really been shown to be that beneficial. Sorry, I had a little glitch here. And so, that now this brings us to the most definitive treatment for erectile dysfunction, and also the treatment that has the highest satisfaction rates out of any that we've discussed so far, which is the placement of a penile prosthesis. The way that this device works is that you squeeze fluid from a pump that sits in the scrotum between the testicles. It's a completely closed system. It's all internal and very discreet. And then that allows you to pressurize 2 cylinders that are placed within those erectile chambers. And you keep the erection however long you would like, and then press a deflation button on that pump that's easily accessible to move the fluid back into the fluid tank. And that fluid tank is generally positioned behind the pubic bone or next to the bladder, underneath the muscle, in a location where it's not very perceptible. The most common side effects or complications that can occur would be pain, postoperative pain primarily. Infection is a rare complication, or mechanical failure, as this is a hydraulic mechanical device. There are a few different kinds of penile prosthesis, but the most common is the 3-piece inflatable prosthesis, is what I've been referring to. The Boston Scientific implant is coated with an antibiotic impregnated coating called inhibizone. That's been clinically proven to reduce the risk of infection, which in general is around 1 to 2%. It is designed to mimic a natural erection, and it is very discreet in the flaccid state. It kind of passes that locker room test, is what I like to say. But it provides a very rigid erection that's good for intercourse when fully inflated. This device has been around for over 50 years, not improvements in various iterations. More than 500,000 men in this country have received an implant as well. So it's something that is not often talked about, is becoming increasingly common. The procedure is generally an outpatient surgery performed under a general anesthetic. So you go completely to sleep. It involves a small incision, usually about 3 to 4 centimeters, just above the penis or on the scrotum. And it's about a 3 to 5 day recovery in terms of, return to a regular routine of light activity. You'll have discomfort for a couple of weeks after surgery and some swelling and bruising that takes time to resolve. But by about 4 to 6 weeks, you're okay to use the implant for sexual activity at that point. The benefits of the implant, well, as I said, it has the highest satisfaction but for both patients and their partners. And the reason most likely is just that this enables more spontaneity than a lot of the other treatments, and it's more reliable. It's often covered by insurance, is covered by Medicare. And it's a long-lasting device. So as I mentioned too, mechanical failure is a risk. 89% of these are still in use at 10 years. It kind of drops off a little bit after that. And, somewhere between 10 and 20 years, men often require a revision surgery to repair a component or replace the device. It's not dangerous if the device breaks. It's just filled with saline. Your body would just absorb it. It just becomes inert or non-functional at that point. And as we've talked about, it allows you to have the erection whenever needed. It does not interfere with ejaculation, should not change penile sensation or orgasm. And and those are the benefits. The risks, we've talked about some of these. Not all patients are a good candidate. This is one of the things that we talk about when considering this surgery. We don't tend to place an implant in and then remove it. Things don't go back quite to the way they were before. Revision surgery is possible. Men with certain conditions may be at higher risk of infection. And there are other risks as well that we would discuss at a formal consult. Now, so ED is a common problem. My job is to help men overcome this, helping you choose the treatment option that's optimized for your condition and lifestyle. And we'll come back to this. I'd love to answer any questions, but I'm going to go briefly into the Peyronie's disease part of this presentation. This is a common condition seen with ED. It is underdiagnosed. What is Peyronie's disease? Well, this is essentially an acquired disorder of fibrous scar tissue that involves the erectile body or the erectile chamber and can cause discomfort or penile curvature here, as well as shortening or other deformity changes. It affects up to 10% of men over the age of 50. But we find that it can affect men of all ages, and about 10% of patients with Peyronie's are under the age of 40. Many men don't report their symptoms or seek treatment, and so, as I alluded to, it's likely underdiagnosed. There are likely genetic factors at play here, but not all men with the predisposition to the condition will develop it. Some of these predisposing factors are things like trauma, so bending injury during intercourse that causes bruising. That can occur. Up to 40% of men with Peyronie's report some history of trauma. Prostate cancer surgery, diabetes, these are risk factors as well. And now the scar tissue can build up and cause the pain and curvature that can make sex difficult or even impossible. It is a frequent source of anxiety and stress that can affect relationships. And so this is, a disease that really impacts quality of life. There are two phases to Peyronie's disease. So when the disease first starts, we call this the active phase or the acute phase. And this is, generally when pain is most prominent, inflammation is occurring. There could be changes that occur in the deformity. And treatment during the active phase, with some exceptions, usually involves supportive care or stretching exercises, optimizing erections. Sometimes it's called intralesional therapy or injection therapy as well for Peyronie's disease can be considered. There's no FDA-approved oral medication that exists for Peyronie's disease, but some are used off-label, and we go over these options at a consult. By the time the diagnosis has been made, though, the majority of men end up with a deformity or curvature that's relatively close to where they currently are. And as you can see from a study here looking at the natural history, about 13% either improved, which can occur, or remain stable. There's about 4 in 10 guys that will worsen a little bit. And so definitive treatment options or definitive treatment decisions, particularly for surgery, are made during the stable phase once things stop changing. Deformity with Peyronie's disease can be highly variable. The most common is a dorsal or upward penile curvature, but it can curve down, which can be quite problematic for intercourse, to the left or to the right, where you can have multi-directional curvature, or what's called volume loss deformities, where you have kind of a narrowing or a hinge or hourglass deformity. And that can be particularly bothersome because it can destabilize the erection and lead to functional problems or even increase the risk of injury. The differences between the types of curvature that develop really relate to how the complex structural integrity of the erectile bodies is affected. These are the corpora cavernosa, the chambers here. And so you have these outer longitudinal fibers, and when those are primarily affected, typically that leads to that kind of upward or downward curvature, but can be to the side. The inner layers here, when these are affected, that's when you can have those indentation deformities or hourglassing. And so, the differences in how the disease presents, it relates to how it's affecting the internal structure, and to some extent affects treatment options. Now, the evaluation for Peyronie's disease is really focused on some key elements in the history that suggest, is this Peyronie's disease? Some men have curvature their whole lives, and that does not cause any problems, is not progressive. And that's not Peyronie's disease. That's a congenital penile curvature that can still be treated if problematic, but is different. And whether a man is in the active or chronic stable phase of the disease. And evaluation may include a study called a penile duplex ultrasound, which is an ultrasound of the penis after inducing an erection. And this is a very helpful way to get objective data about the scar tissue, about the deformity and blood flow through the penis. Treatment options really depend on a lot of different factors and are individualized to the patient and their disease process. It's critical to tailor that treatment option for the patient, and the primary objective here is just normalizing or restoring the ability to have intimacy, especially as it's been affected. And so for some men that can just be observation or supportive care. Other men, it may involve stretching exercises, traction therapy is what that's called, or a vacuum device. Another treatment option is intralesional injection therapy. So injecting the scar tissue with a substance called Xiaflex is the only FDA-approved non-surgical treatment for Peyronie's disease. And we find that a series of injection treatments can improve curvature on average around 34% or so. And then in surgery. So surgery, there are different forms. There are straightening operations called penile application. And there are plaque interventions as well. So cutting out that scar and replacing that with graft material. And a penile prosthesis may be a component of a complex surgical treatment option for Peyronie's disease. So as you can tell, this part of the conversation is a little bit complicated, and it's my job to kind of navigate that with you and help you understand all the pros and cons to all the various options. And we sort through what's the best option for you whenever we have the consult for this. So I'll start to wrap up here. Boston Scientific has created a helpful resource of information here. I'd encourage you all to access after this webinar. Has a lot of helpful videos, and this is a QR code that you can get to. And so with that, I'll open it up to questions.
Mind, Dr. Greear, transition to Cliff.
I'm so sorry, Cliff. I really appreciate you being on this call. I mentioned you at the beginning. I would love to have your patient perspective on this as well.
Sure. Good evening, everyone. What you're going to hear is the journey that I and my wife took when I developed ED after prostate cancer. When I was 57, I was found with prostate cancer, and even though it was just one little spot in the prostate, my wife and I talked about it and decided the best thing to do was to remove the prostate. And we had it removed. And after I had it removed, basically, I ended up with ED. I went back to my regular general physician, and they put me on, excuse me, they put me on my first pill, Viagra. And unfortunately, my response to Viagra were terrible, terrible headaches. So bad that I would have to lay in bed and just could not pick my head up off the pillow. So they traded me over to Cialis and then Levitra. Same problem with all three. No erections and terrible, terrible headaches. From that, I went back to my general doctor again, and he suggested the external vacuum device. As Dr. Greear said, it does work, and it works well. Unfortunately, there are some issues with it. Number one, it is not very spontaneous. So you have to stop what you're doing. And it always seemed that the more excited I was with having been able to have intercourse, the longer it took to pump it up and put on the band. My wife has said that it didn't, your penis does get cold. It kind of turns a little blue. It's not very appetizing for your partner. And my problem with it was bringing the band off of the penis up the shaft was no problem, but getting it over the head really, really bothered me. So basically, after going through this for 6 months, I went through a 2-year depression. Totally lost my manhood, didn't know what was out there, was never referred to anybody, and unfortunately was never told that ED was a possibility of the prostate cancer removal. Well, finally, I did get a letter from a group of docs who are prosthetic urologists who basically had covered what we've covered tonight, which were the little pellets, the injections, and the 3-piece device. Injections were not relatively my favorite idea. The Muse was not really my favorite idea, but the 3-piece device really caught the attention of myself and my wife. And I will say this to you right now, ED is not just a male issue, it's a partner's issue, it's a couple's issue. And I really feel that if you take your partner to the physicians that are going to talk to you about how to fix your ED, it's much, much easier because they then understand what the problems are. And they realize that basically a lot of women feel they're the problem, and they think your husbands are having affairs and stuff like that. And that's the farthest from the truth. And they learn that what it is it's a disease that can be fixed, and it's not really caused by somebody going out and being unfaithful. We spoke to the doctor, and I learned about the 3-piece device. And after talking with my wife about it, we decided that was our best solution. So when I was 60 years old, I got the 3-piece device. I had a very, very easy recuperation time. I've got a very high level of pain level. And I was able to just take Advils to basically put me into a nice, quiet mood without much pain and without a lot of discomfort. After 2 weeks, I went back to work. On the 4th week, I went back to the physician. He showed me how to use the device. And he said, use it a few times a day until you're used to it. And then basically he said about the 6th week, if you're feeling good, you can start having relations again. And needless to say, 6 weeks came. We started having relations again. And I will tell you that you really do not realize how much intimacy you lose when you give up the concept of having intercourse and making love. What it does is it brings you back to being a full man. You've lost your manhood, and this restores it. I had my device for 14 years, and then it stopped working. I went back and had it removed and a new one put in. I will say that the removal and the second surgery to have it implanted was a lot easier than the first. It went much quicker, and the recovery was much faster. At the end of the 6 weeks from the first surgery and from the second surgery, I basically went back to working out at the gym with my friends. We showered together. They have absolutely no idea there's anything inside me. My wife has said many times, had she not known me prior to having ED, she really could not tell there was something inside me that was not natural. It gives you a natural erection. It's a solid, rigid erection for any type of intercourse you want to have. People ask me a couple of things like, when you go through the airport, does it go off when you go through the metal detector? The answer is absolutely not. Also, my knees do go off because I have 2 artificial knees. So I don't know if you've ever been wanded. They take you over to the side and they run this ridiculous wand up and down your body on the inner side of your thighs and around your crotch. Nothing happens, nothing goes off. people ask me, well, does this stop you from getting MRIs and CTs or scans of any type? The answer is no. But the biggest question they ask is, does it interfere with urination or have anything to do with bladder problems? And again, the answer is absolutely not. It does not affect your urination nor your bladder. As a matter of fact, I've had 2 cystoscopies since I've had the first implant, and I went to this urologist and very funny, he looked at me and I said, wait a second. And I just gave a few little pumps and got semi-erect, and they put the camera in me and he said, boy, that was nice and easy. I wish all my patients were like that. It really, really helped. It was not a problem at all. Finally, basically, I would tell you that if you want to restore your manhood, you want to restore your intimacy with your partner, the only way to do it truthfully is with one of these solutions that the doctors have talked about. Sorry, excuse me, that the doctor talked about. And it will take you to the next point in your life where you can once again feel like a full man and be a full participant in making love with your loved ones. So I will turn it over back to Dr. Greear and answer any questions anybody might have.
Cliff, thank you so much for that. That's right. Your story is it's motivating, and I think it kind of encapsulates why I do what I do. So thank you for sharing.
Thank you both for all the information you've shared. Like your sharing is people feel open and willing to ask a lot of questions, and we have several here tonight. Dr. Greear, the first one, gentleman who's in his 70s, has been experiencing sexual function, looks like for over 2 decades. Is it possible that this gentleman can find a solution that will help him have intercourse?
Yes, absolutely. I am just looking at the chats here. I think I am so glad that you joined the presentation today because the answer is yes. I think you're the kind of guy who I would love to have a consult with, and we could sort through what to try first, and sometimes it is a little bit of trial and error, but we can settle on something that and we'll figure it out together. So yes.
So maybe the same gentleman has tried injections, doesn't like, and they don't work. And you've gone over this, but after injections, if those are not working, what solutions are left?
So, injections are a very potent treatment, and I think I'm reading your question in that they work, but you don't like it, or if it doesn't work, then sometimes going from injections, if injections don't work, often the pills are not going to cut it because it's just such a potent treatment. One of the mechanical solutions, like the vacuum devices, would probably work for you, but ultimately, it sounds like you would be an excellent candidate for a penile prosthesis, and would find that very gratifying. So. That would just give you more spontaneity than what you're experiencing with the injections currently. And similarly, if you just don't like it, I never tell patients who come to me, for example, after they've been in a situation like Cliff, where they've had prostate cancer treatment and the pills aren't working, do I have to try the injections? The answer is no. And our guidelines organizations support that. They say that, the ED treatment algorithm is not predicated on any sort of stepwise progression. So the implant is always an option. Some of these other mechanical solutions are also an option.
For a patient who is diabetic and experiencing ED, the question is, what should I look for to make sure I don't develop heart disease? And maybe, is there any tests that they can do to see if they are on their way to developing or have cardiovascular disease?
Yeah, this is a great question. Some of the basics are just, you have diabetes, and so making sure that that is as tightly controlled as you can make it, that is going to be probably the best thing you can do. Blood pressure control, cholesterol control, making sure you're getting regular cardiovascular exercise. These are the things that are going to ward off both, progression of ED and the development of heart disease. There are more sophisticated screening tests for heart disease, such as a coronary calcium score, where they get a CT scan of your heart and look for evidence of coronary artery calcification. That is something to discuss with your primary care physician, and I'm sure that they would be able to help you with that.
Thank you for that answer. Now, for somebody who's had robotic surgery, removing their prostate, can you speak to the results of the wave therapy in helping with side effects of prostate removal? And if this is effective for ED and any other side effects that somebody might have?
Yeah, this is a great question. Unfortunately, the data for ED post prostate cancer treatment is not favorable for shockwave therapy. It does not mean that some people will not improve, and it doesn't mean that you can't elect to try that. But the results have not, the results in our center and in, just larger studies, it doesn't seem to be as effective in your situation. It doesn't mean that there aren't other treatments, but it's so that's the answer there.
Dr. Greear,
Transitioning over.
Oh, go ahead.
Chip Arnold's taken over with the Q&A duties at this point.
Okay, thank you, Mike, very much for helping out.
Thank you, Dr. Greear. Thank you, Cliff, and thank you, everyone.
So I think we addressed this peripherally, but there's a question about the association of ED to vascular disease. Is there a synopsis you can give, maybe the canary in the coal mine discussion?
Yeah, absolutely. I can flip back here to one of these slides here, where there is definitely an association of ED to vascular disease. And what we find is that because the penile arteries are smaller, and if they're affected earlier by conditions that narrow arteries and affect their health. And so ED often precedes coronary artery disease or heart disease by 2 to 3 years or more. And so there's a strong association there. And so ED, as you were saying, Chip, it can be the canary in the coal mine for heart disease, which is obviously more lethal.
So that might be a scenario where they'd make an appointment with a cardiologist or PCP for the CT scan.
Right. So that's that sort of higher, more sophisticated screening for cardiovascular disease is offered by most PCPs. There are some insurance eligibility things that I'm not privy to, but that test exists. There are other more simple tests, which is just what is your exercise tolerance, for example? Are you able to climb up several flights of stairs? Can you walk around the block? Can you go down? Can you maintain a jogging pace for a mile? And so some of these are just proxies for your risk for heart disease as well, and cardiovascular fitness that are important.
Awesome, insightful. Here's an interesting one. Have you seen, or the patient says, have seen photos on the internet where it looks like two pencils inside of a penis? I assume with the penile prosthesis. Could you use some clarification of that? They're wondering if they all like this.
Yeah, sure. So the modern Boston Scientific inflatable penile prosthesis it expands in a girth dimension, and then one of the main models, the LGX model, expands in length dimension as well. You may be referring to a malleable penile prosthesis, which is a non-inflatable type, and so that's essentially the more modern version of that. Has a nitinol core and a silicone construction. And so it's a simpler device. I didn't go into detail about it because it's not as common in the United States. It actually is more common than the inflatable device in Europe. just interestingly, I think by practice patterns. It's simpler in that, it provides good axial rigidity, meaning it, for penetration, you bend it down when you don't want to use it. So it kind of tucks against your pant leg, bend it up when you want to use it. There are some patients for whom this is a good option. There's some use cases when we rely on the malleable prosthesis, but in the United States, the most common and the most natural appearing and that mimics natural erectile function is the inflatable.
Excellent, thank you. It sounds like we customize to the patient and to their needs.
Correct.
This question is regarding amlodipine and the side effects. It says, does prostate seed implants cause ED over a number of years?
So prostate seed implants are a form of radiation therapy for prostate cancer. And it definitely can cause ED. Brachytherapy actually delivers the highest local dose of radiation out of any of the radiation modalities that exist. And so it can be very effective for curative purposes for cancer. But over time, radiation is also kind of the gift that keeps on giving, in a sense where you can have progressive effects years after your treatment was begun.
Yeah.
And amlodipine, these antihypertensive medications, some of them can cause or can be associated with ED. In the end, it's important to maintain blood pressure control to prevent ED from worsening. And so often it's a symptom, when you start a blood pressure medication, it's a symptom of the underlying cardiovascular disease as to when erectile dysfunction develops after starting one of those medications. So sometimes different medications have different side effect profiles. And so some men have to transition to one or the other before they figure out which one has the lowest side effect profile for them. So anyways, hopefully that addresses the question about amlodipine.
Sounds good. This is in regards to Peyronie symptoms, and the person is using Viagra and injection therapy alternatively, and they're starting to experience some Peyronie. So there's some question about that.
Sure. So, scar tissue and Peyronie's disease, it can be a side effect of injection therapy, not so much a side effect of Viagra. The best way to avoid that is to make sure that your injection technique is excellent or as good as can possibly be, trying to maintain and minimize any sort of bruising or bleeding after an injection by holding pressure for at least 5 minutes. It's possible that if you have a little bit of bleeding within the lining of the erectile chamber, that can cause inflammation and develop and lead to scar tissue. Some experts also think that kind of overly frequent injection can increase the risk of scarring. This is like people using it daily. So usually we try to say, try not to use injections more than 2 to 3 times per week. There's very few randomized trials, for example, that are going to explore this issue, but those would just be the tips I'd offer you. And if you are experiencing Peyronie symptoms, I'd be happy to see you and kind of go over what can be done.
Mm-hmm. Like Xiaflex, for instance, but we have a very engaged group. So I'm going to skip around just a little bit, unless there's something you see that you want to address. But I saw one, it's a partner question. I'd like to honor that as well. So it says, the vacuum device, does the penis become fully erect? The 3-piece penis, is it harder? And so that's a question. That's an important need for that patient or that partner of the patient.
Sure. So the let's see, the vacuum, the external vacuum, I assume you're describing, it does mechanically pull blood into the penis. So the penis does become fully erect. To maintain that, generally you have to use that constriction band, and sometimes that fit can be difficult. And so for men in whom they figure it out, it can be a good solution, and it kind of maximizes the anatomy. The 3-piece device, I would say, is just as rigid. I don't know that it's difficult to compare hardness, but it's just as rigid as the fully rigid erection. And so I will just kind of direct you back to the well research data that shows that, not only do the patients have a 97% satisfaction with the implant, but their partners, it's a 98%. So I think you would be in good shape.
Sounds good. I'm going to try and bring a couple of these questions together just with interest and time.
Mm-hmm.
There is a question about stretching device and Peyronie's. I'm gonna try and give it to you all at once, and hopefully you can bring them all together. I'm looking at the end, the final question there. There's a patient that has extreme left angulation with their Peyronie's disease. There is a question about how many devices you do a month, but that's probably worth getting to as well. But getting back to the Peyronie's, there's continue to have ED after the Peyronie's and Xiaflex. Have you tried medications? What would you recommend after having tried medications? I'm going to leave it there and hand it over to you.
Okay. Sorry, I'm trying to find these ones as well. Okay, so let's see. After Peyronie's and Xiaflex treatment, a penile prosthesis is a possible component of a solution, especially in men that have Peyronie's and ED. And that's because we can do maneuvers at the time of a prosthesis placement to correct curvature. It's called penile modeling. And it's a great solution. And generally, we for moderate curvature, we're able to correct to less than 30 degrees or so is the goal, and usually between 10 and 20 or so. And for severe curvature, for severe leftward curvature, for example, sometimes we may be talking about more advanced reconstructive maneuvers, depending on what they've tried so far, what that looks like. And so that's one of these situations where it really has to be individualized to you, and I'd have to examine you and kind of see what we need to do for you. But that's obviously when you curve that much, it can make sex very challenging, and so getting you back to intimacy is important. Let's see, ED. Let's see, still. Sorry, Chip. It is hard to lump all these together.
Yeah, I know. I'm sorry.
No, that's okay. These are all excellent questions.
They are.
The Restorex device, the Restorex. So Restorex is probably the most widely utilized traction therapy device for Peyronie's disease. It was developed in conjunction with the Mayo Clinic, and so they have some good data to support its outcomes. Basically with consistent use, it's a little bit of a contraption. You work your way up to using it for about 30 minutes twice a day. But it can reduce curvature on its own by about 30% or so, and help restore penile length that's lost with Peyronie's disease. It's the analogy I give is it's like physical therapy for your penis. You often have to kind of continue to use it to continue to receive the benefit, but it's a great non-invasive option for a lot of guys with mild to moderate Peyronie's disease. How many implants do I do per month, per year? Over the last couple of years, I've done probably somewhere between 100 to 150, and it is variable. The volume varies, as Chip can attest to. And so coming up next month, I think we have about 4 or 5 or so. So that's the question. I'm obviously earlier in my career, but this is what my fellowship training is in, and so I've done a lot of these.
Yeah, and I'd also
as many as some others out there for sure, but yeah.
Yeah, being a subspecialty, that actually puts you in the higher volume implanters in Colorado. So I think that's worth noting because we're not talking about hips and knees here. We're talking about a subspecialty where you're dealing with a select clientele. We maybe have time for one more question. Is there one you'd like to pick, or
let's
I
see.
can pick one.
Yeah, I think One of the last questions here in the Q&A was, can ED therapies be used along with Medtronic bladder control therapy? I think that's another, important thing that we really haven't touched on, which is that BPH and ED are very common together. They can be treated synergistically. Some medications can help both, like Cialis, for example. The penile prosthesis, there's no contraindication for having that placed with any, InterStim or Medtronic device. Or other BPH treatment. So that is a good question. And we have many experts at our center, at the Urology Center of Colorado, who treat all aspects of urologic health. And so we have a very collaborative environment. And so I see most of the guys with sexual dysfunction. I send my patients out to, folks with prostate cancer, for example, to the people who are best able to help them. It's great to work in an environment like this. It enables me to help the most people and kind of develop the best treatments for them. So thank you all so much for joining, for all these excellent questions. I'd be happy to kind of discuss further in another time too.
And Dr. Greer, could you let everyone know how they can get in touch with you? There's a question about how someone would make an appointment. And maybe while we have that up on screen, we can ask one more question, if that's okay with you.
Sure.
I know we're pulling you away from your family, but ED still 10 months post prostatectomy. I think this is a very common question, so I'd like to address it. Thank you for your time. So injections work, but the question is, when should I seek further treatment if ED doesn't resolve?
Yeah. So the natural history of the recovery of erections after a prostatectomy, a nerve-sparing prostatectomy in particular, is that the majority of the improvement in your erections is probably going to occur somewhere between 12 to 18 months after surgery. It is a bit of a plateau effect. So, after a year to 18 months, the marginal increase in function tends to slow. Injections work. It's an excellent solution. It also means that, if you're tired of using it and you want to consider one of these other more definitive treatments, doesn't mean you have to wait the full 12 to 18 months just to move on to a more definitive solution like the implant. We've placed implants before, for example, in men who have ED, that before they have a prostatectomy, and we know that this is going to be a long-term issue to minimize things like shortening and fibrosis. We've placed implants before just 6 weeks after prostatectomy. So, I think that natural history is important to understand, to kind of give you encouragement. But just know that, at any point you can always come in and we can escalate treatment for you.
Excellent. Well, thank you so much. And I'd like to also just call out Cliff and say thank you so much for the time and care. I know you do this out of just your care for other patients out there, and it really resonates. So thank you for taking time this evening. And several of the comments in the chats have also been thankful for you being here, Cliff.
Thank you.
Dr. Greer, we really appreciate you being here, of course, and your expertise is, I think, enlightening for a lot of people. We look forward to doing more in the future, and please, everyone, feel free to reach out to Dr. Greer if you need to discuss anything more with him. And with that, I'm going to conclude the meeting, unless anyone has anything else to say.
No, thanks, Chip. Last question, I did not mean to ignore. There was an attendee about whether curvature can go away by itself. If it is related to Peyronie's disease, there is a small section of patients in whom curvature can improve, and the majority stabilize. So hopefully that answers your question. And I did not mean to ignore it. So anyways, Chip, thank you for your help, and you guys all have a great night, and we'll meet again.
It's my pleasure. Thank you.
All right.
Good night.